3 years of treatment of tetralogy fellow. Um, of course, the approach you take depends on your own institutional comfort and the surgeon's comfort. If the surgeon is comfortable repairing tetralogy fellow in the newborn period, obviously you could go for a primary repair. If not, you could palliate with a systemic shunt, systemic to pulmonary artery shunt, like a blood-lactosic shunt or aortopulmonary shunt. The older shunts like water stent shunt and port shunt are out of favor because they have significant complications. There is I would say there is no harm in palliating a patient and going for a tetralogy full repair later on, if that's what is ideal in your setup. But our approach has been to do primary repair in these patients. So if you have to do primary repair, then you have to find out what age do you do, whether when the patient is symptomatic or whether electively in all patients. Our preference is to do elective repair in all patients by between 2 and 3 months of age. However, if the patient becomes symptomatic before that, then you do primary repair even in the newborn period. And that brings us to patients who have pulmonary atresia. We tend to repair all patients with pulmonary atresia in the newborn period with a RVDPA conduit. The pulmonary artery size is another factor which determines whether the patient should be operated in the newborn period or not. There are several indices which are designed. There's a Magoon ratio, Nakata index, Kirkland's formulas, but all these formulas were evolved during later repair in children or young children or older children, but they don't necessarily apply to neonatal repair or early infant repair. If you take a newborn baby, 3 millimeter pulmonary artery is adequate size. But if you calculate the Nakata index, they may not be in the category of early repair. If you take a patient with pulmonary atresia, supplied by ductus arteriosus completely, if those patients are completely, most of the time, fully repairable, because if their saturations are more than 85%, that means the pulmonary vascular bed is already having a QPQS of more than 2:1, regardless of the size of the pulmonary arteries. I think the size of the pulmonary arteries becomes critical when you don't see a PDA in the fetal life, and the pulmonary arteries could be hypoplastic, or hypoplastic pulmonary arteries seen more often in patients who have syndromes like Alagille syndrome or unknown genetic syndromes where the pulmonary arteries are very hypoplastic. Those patients would need a separate management to grow the pulmonary arteries with a aortopulmonary shunt. What are the advantages for doing a primary repair? Obviously, you avoid the shunts and stents. You avoid any preoperative complications by going a early repair. You avoid unnecessary effects of hypoxemia, and you prevent RV hypertrophy and their sequelae. And also, I think you normalize the preoperative physiology of these patients, and that probably helps in development of the other organs. Plus, you have the psychosomatic benefits. Parents are not worried that the patient is going to die anytime with the spells. That also is an additional non-medical benefit. There are the potential disadvantages. Increased mortality. The smaller the patient, the higher the risk. Or is there an increased incidence of transanular patching? These are the two, I would say, potential disadvantages of this early approach. So what are the potential advantages? If we look at the shunts and stents, there is significant impact on the development of pulmonary arteries, jailed pulmonary arteries, and discrepant development of the pulmonary arteries. The higher mortality with the shunts is very well known. This can be avoided by doing an early repair. What about the other advantages? If you look at the cyanotic spells, nearly 74% of the patients before the year of 1 year have 75% of them have tetralogy of cyanotic spells. But if you do an early repair, I think the incidence of hypercyanotic spells is very low. Even then, you probably have to repair sooner enough in life to prevent any of the hypercyanotic spells. But most of the time, the hypercyanotic spells can be treated medically unless they happen in where there is no medical facility. What are the other advantages? It's been very well known that if you do an early repair, the alveoli and the lung and the vascular development in the lung is very beneficial with an earlier repair. The later you repair, the worse the alveolar development is. It's very well known. Like if you have a patient who comes for a hyperplastic pulmonary artery, and you try to rehabilitate that pulmonary artery after 5 or 10 years of life, that pulmonary artery, even though if it grows, the lung associated with it doesn't oxygenate very well. So that's because of the problem with the alveologenesis and the angiogenesis. What about the RV hypertrophy? It's very well known the RV hypertrophy results in arrhythmias and diastolic dysfunction. By doing an early repair, obviously you can avoid this. Because I told the unrecognized benefits are mostly psychosomatic for the family and the child. What about in general well-being of the patient? It's been shown that early repair has better outcome in terms of their exercise performance, probably related to their decreased diastolic dysfunction in early repair. So, what about the effect of the potential disadvantage? One is that in transannular patch, if you do early repair, is the incidence of transannular patch increased versus late repair. We looked at our own data when we were at UCSF in the 90s, when we measured the pulmonary annulus on patients who were presented at birth, and when they came back for repair at 2 or 3 months of age. You can see that the annulus doesn't grow in a short period of time, or if you do a shunt. The early repair is better off in saving the valve, in my opinion, at least in our experience. When we looked at our data at that time with UCSF till 2001, we could see valve sparing repair of tetralogy of in 71% of the patients. I think that's between early repair. But is a transannular patch so bad? Probably the data indicates, especially if you take older patients from in the 70s and 80s who were operated, I think they transannular patch, they did much better with transannular patch because they were operated later in life, the RV was already hypertrophied, and with the transannular patch, it took a longer time for the RV to dilate and needing a valve replacement. Whereas the early repair, if you do a transannular patch, the chance for the RV to dilate is much more frequent. So I think if we do an early repair, it's much better to save the valve as much as possible. And if you look at the mortality with transannular patch and without transannular patch, they're pretty similar. That doesn't necessarily mean that we should stay away from repair. The patient needs a repair in the first year of life. And there's like a meta-analysis from several institutions. Age less than 3 months was equally risky for a shunt or repair. So I think our preference is to do a repair. I think in our opinion, the risk is much less the full repair than the shunt. The shunts carry higher mortality. It is very well shown that shunts have a higher mortality in general when compared to full repair. But with the advent of ICUs and ECMO and stuff, it could salvage most of the patients, but still the complication rate is fairly high. Sorry, the complication rate is fairly high with shunts. So our approach is to always repair these patients. Age more than a year was associated with significant mortality. This was from a report published from Toronto Sick Children's Hospital. Obviously, I don't have any experience with that because we repair these patients early enough, and they found that early repair has an increased incidence of a stay in the ICU and also increased incidence of atrial arrhythmias and a longer period of ventilation. But I think those things can be gradually decreased with your experience. And in another study, they found that no difference between early repair between less than 3 months or more than 3 months. So it all depends on your institutional benefit and your experience, I think. If you take the literature, you can argue and for and against early repair versus late repair. So I think when they looked at the large database set in STS, they found that there are institutions who routinely do primary repair. The results are very good even under 4 months of age. But people who do not do routine repair under 4 months of age, they are better off doing a repair beyond 4 months of age and palliate them early. So overall, I think the results were relatively equal. But if we have a patient with a duct-dependent physiology, like pulmonary atresia, we would prefer to do a repair rather than a shunt, because a shunt in a newborn period carries a higher risk than an elective or a repair in the early period, early newborn period. But if it's acyanotic, we routinely repair between 2 and 3 months of age. But if they're symptomatic, we will repair whenever they are symptomatic, even before 3 months of age. So we usually general standard cardiopulmonary bypass, which clinic will elaborate. And I think I would generally do a mild to moderate hypothermia depending upon the age and size of the patients and the complexity of the disease or the outflow tract obstruction and where the VSD is. If the VSD is what we call an outflow tract VSD, like we call it there's no conus and the VSD is right below the pulmonary valve. Those are easy to repair on a mild hypothermia because most of them you could close it with outflow tract patch. But if the patients are small and they're less than 2 kilos, I'll probably go deep hypothermia all the way to 20 degrees. We always use cardioplegia in these patients. Standard cardioplegia we use, a modified St. Thomas solution, but I think various surgeons use different techniques. My colleague here from Hanoi, he uses, I think, Brett Schneider's, right? Yeah. And some of them use Del Nido plegia. But I found that regular St. Thomas plegia with a little bit of blood in it works as well. But my professor, my mentor, Dr. Castaneda, used to say that cold and potassium are more important than all the fancy solutions. We try to do our repair, save the valve as much as possible, and transannular patch is when indicated. I would say, but if it's a premature baby or low birth weight baby, I always try to save the valve. They do much better with a competent valve, even if you have to reoperate 6 months or 1 year down the road. The results are much better if you save their valve. And we always leave a little bit of PFO to unload the RV during the diastolic dysfunction. So how you close the VSD is quite important, because if you do a surgery in a small baby, closing through the atrium can be very challenging for inexperienced surgeons. So you could definitely do a ventriculotomy and close the VSD. So that's something which I think you feel comfortable. Now, as we gain more experience, I try to do most of them through the atrium, through the transtricuspid approach. You have to. Roger Mee was one of the first surgeons who advocated transatrial transpulmonary repair of tetralogy fellow and sparing the valve. And then he would do infundibulary resection partly from the right atrium through the tricuspid valve and partly through the pulmonary valve after the pulmonary valvotomy. I think those things work quite well in with experienced surgeons. But also, you have to make sure that how you do the pulmonary valvotomy is very critical. So you should always make sure that the valve is split right in the commissures if you're doing a transannular patch. And then if you split the patch, if you go transannular, you make sure that the patch is not very big, so it doesn't splay open the valve and cause free regurgitation. So you can try to minimize the regurgitation as much as possible by limiting the transannular patch size and the extent into the RVOT. And obviously, if you have to do a regular transannular patch going further into the RV, you could use a monocusp valve with a Gore-Tex membrane or with atrial appendage or with fresh pericardium, all those things can be used for a monocusp. But these monocusps generally have a limited lifespan, and they help you benefit in the early postoperative period, and subsequently within a year or two, the monocusp doesn't function anymore. So this is I'm used to operating small babies. This is one of the smallest tetralogies I've performed with a 7mm homograft in a pulmonary atresia. So during our experience, my experience is over institutions, over 30 years from UCSF to Stanford back to UCSF. So this was our early experience at UCSF. We routinely repair all the tetralogies under 3 months of age. I'll just quickly go over, but most of them are drug dependent. Most of them were elective, 32 of them. Some were operated because they were symptomatic before 3 months of age, and 17 of them had pulmonary atresia and were drug dependent. So I will keep all these slides. The early mortality was about 2%, 2.8%, and late mortality was 1%. This is highly acceptable results for even early repairs. And reintervention is often required if you do a transannular patch. If you do the valve sparing operation, they probably come back for reintervention to go across the annulus in some patients. Most of them were related to that, and some of them had a ductal stenosis of the LPA and required balloon ablation. This was the old follow-up, so I won't go into that. But in general, the growth of the annulus after repair, you can see the annulus grows in these patients. Without repair, I think the annulus doesn't grow because blood flow across the annulus is what causes the annulus to grow. So this is our subsequent experience from 2001 to 2012 at Stanford. After 2012, I don't have the data, but these are the similar results. You can see the mortality was similar, exactly. Late mortality was similar. So only we never did a shunt in these patients. There are 150 patients. Only twice we did a shunt because of medical reasons. The patient couldn't put on a cardiopulmonary bypass. So early primary repair can be performed very safely in these patients with minimal mortality and morbidity. The need for transannular patch can be minimized if we do an early repair, but that's also depends upon the morphology. But the transannular patch incidence is lower, in my opinion, if you do an early repair than later repair. Early repair allows for the catch-up growth of the pulmonary valve annulus size over time, and early repair does not significantly increase the need for reoperation. This is offset by reserving the annulus and avoiding late repair of the pulmonary valve. With the exception of very premature infants and those associated with serious non-cardiac defects, tetralogy failure can be repaired with close to zero mortality with techniques which are tailored to morphology of the patients. Thank you.
Thank you very much, Professor Mohan, for your inspiring presentation. Your expertise adds great value to us. Next, we would like to invite Clinton to present the topic perfusion strategies for TOF. Dạ, bài này có phiên dịch ạ.